Hey everybody, welcome back to the Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got my regular crew and colleague here, Dr. John Hill. And today we have Tony Carino, who is the Adult Respiratory Clinical and Education Coordinator at Cleveland Medical Center. I've got this word wrapped on here four times to getting your entire title on there. And additionally, this is kind of the important part for this audience. So not only are you an RT and a RT educator, you're also a paramedic and have been for 20 odd years.
About 20 years.
Yeah, and we wanted to have you on. Really, there's in this area. There's been this kind of I don't want to call it a push, but there's been an interest from some departments to bring advanced ventilatory techniques and devices into the municipal services or some of the transport services that are servicing nursing homes that have ventilator population. And they used to be very, it seems like that whole population is spread out over a lot of the nursing facilities, where it used to be, there was 2 or 3 places in the region that specialized in vents.
Right.
And it doesn't seem to be the case anymore. And we see, my observation has been there's kind of more and more out in the periphery, and they're being managed locally. And I applaud these departments for stepping up and wanting to do more. And in a couple of cases that we're gonna kind of talk about, is they've gone out and acquired more advanced ventilators than what would typically be seen in the pre-hospital space.
Sure.
Noting, of course, that what's seen in the pre-hospital space is very limited to begin with.
Right.
So let's kind of talk about, start off, what is kind of different between the devices that maybe we have traditionally seen in the pre-hospital space for departments that have wanted something like as a resuscitation adjunct for an arrested patient, so like an auto vent or or a parapag or something along that, a gas powered device, versus some of these more complex devices that these departments have elected to go out and get their hands on. So kind of a brief overview, the differences between these, and can they overlap, and should you be using those resuscitation vents on that nursing home population?
Yeah, I think it's, first of all, thank you for having me.
Yeah, no, I appreciate it.
It's safe to say that as time has gone on, technology's gotten better. I mean,
100%.
we can say that empirically about the medical industry. When it comes to ventilators, same thing applies. We are used to, in the past, having some very kind of crude, basic gas-driven machines that are used maybe outside of the hospital in a nursing facility, or even in the home care setting. But then when they go to the hospital, they're placed on an ICU type of ventilator that had much more capabilities. Nowadays, though, the transport ventilators have kind of caught up with that, with the ICU capabilities. So there's some great products out there. We use a particular one in the hospital that can compare to our ICU ventilators and do almost every single thing that the ICU ventilators can do.
Absolutely.
At the same time, though, the home care ventilator market and the LTAC ventilator market has also gone that same path of increasing in technology, increasing in capabilities. So as their capabilities basically increase, we need to be able to do the same thing in the transport world. So it's not really an option anymore to have someone who is on a more technologically advanced ICU type of ventilator in a nursing home be placed on a gas-powered ventilator that's very crude for the transport. It's not going to do well. And actually you can cause more problems than if you hadn't used it in the first place.
Yeah, just a time cycle device. It's like, okay, you tell it how much you want and how often, and basically it's an automated BVM. And these cruder devices, these oxygen power devices, it just says, okay, it's time.
Yeah.
Whether they were ready for the breath or not, there's take all those. Just here it is, right?
Yeah.
Take it or leave it.
And that's essentially what it has come down to, is how do we make these machines more refined and more comfortable for the patient?
Sure.
Our LTAC patients and our home care patients, most of them are not, they're not sedated. They're they most certainly have breathing reflexes of their own.
Sure.
So it's how do we make these machines so that it is going to jive with the
Yeah.
patient, be more comfortable for the patient. And as you're saying, the old ventilators were time cycled, gas powered. They didn't necessarily care how fast the breath went into the patient. They didn't do a great job at paying attention to the pressures that were delivered. And they had very, very limited settings, whereas nowadays we can fine-tune these ventilators in the transport setting to accompanying whatever the patient's needs are. If the patient wants to breathe faster or breathe in at a higher flow rate, the machines can they automatically detect that, and they can do that. So whereas on the older machines, you'd end up having some dysynchrony or asynchrony because of that, making the patient uncomfortable.
The dysynchrony is the hardest thing to troubleshoot with a vet, in my experience, right?
Sure.
Because it's working with this complex machine with a human being who doesn't breathe on a regular basis, and even if you have the opportunity when you're in the hospital, we put them on our fancy machines and they're measuring breath to breath and how much a breath changes from second to second, and then talk about leaks too, and how all that mass, like I might have a big leak, so I might have a huge volume, but even volume to volume, like, oh, that breath was 400, this breath is 500. Oh, they paused for a second, then they took a big breath, and that was 800. Well, that's not 4 per kilo, that's not 6 per kilo.
Yeah.
We'll get into when we're driving the patient, but dysynchrony becomes a big issue and can cause harm, right?
Absolutely.
If we're talking about air trapping and stuff like that, which we'll go into.
You're inadvertently kind of outlining, the basis and the reason that we're doing this podcast is if you're going to do this, if you're going to take this step and you're going to do these more advanced techniques out in the field, is you have to have a great understanding of the ventilator physiology and how it's interfacing with the patient. Obviously, you have to have a knowledge of whatever specific product that you're using, but there is, there's also those departments out there that are like, hey, yeah, I want to do that because the guy next door is doing it, right? That comes with a huge commitment in education. That comes with a huge commitment in training. It's not just another thing you can just, it's not like, I don't want to pick on Broslow, but if, a color-coded PEDS kit is a color-coded PEDS kit. It doesn't matter whose name's on it. You can, with very minimal training, say, hey, the stuff's in these pouches versus, these slots. It's not like that. It's not just another thing you can throw on the truck and say, go be great, and your paramedic knowledge, your basic training. Is insufficient. I'll just straight up say it, right? Is insufficient. As a paramedic educator myself, I know what curriculum I have to outline to my students and train them to. Obviously, I try to go a little bit above and beyond, but even what we're about to talk about here is well beyond what we talk about in paramedic school. Even as I'm trying to go beyond, just squeeze the bag once every 5 to 6 seconds, right? And that's not what this is.
Well, you've got an advanced device, right, that we have literally a whole specialty on.
Sure,
right? And to the point where I'm in the emergency department and I've got an RT next to me and we intubate or we do whatever. They're like, what do you want my settings at? I'm like, whatever you want to do.
What do you want the settings?
What do you want to do? Oh, those sound great. Let's absolutely go with those. And you please manage the vent. If you need me, we can have a conversation about something. But I want to adjust this, or I want to increase volume. Yeah, whatever you want.
Yeah, and that's the great thing about being in the hospital. We have a large team that can kind of come together and say, okay, you're the expert in this, so you handle that largely. But in the field, a little bit of a different story. We've got maybe 3 of us if we're lucky, and sure, we have medical control that we can call with for input and stuff. But to the point of what's different between the old school ventilators and what we were used to and what we have available to us now, not only are the settings differently and the way they deliver breaths different, but they're also monitoring things that maybe we weren't able to simply monitor before. Now we have the capability to look at waveforms and different types of ventilator or pulmonary mechanics, compliance, resistance, IDE ratios. We can pull up all of these things right in front of us. But to your point, if we don't know what they mean, what good is it? Right? So is it worth a department spending $20,000 on a transport ventilator that no one knows what's on the screen.
Yeah.
No. So, along with the advance in the equipment comes with the need for advancement in education. And, we could say the same for, how it was when we started getting the newer heart monitors.
Absolutely.
When I first became a medic, and you guys can attest to this too, we had a 3-lead in the field, and that was it.
We've talked about this extensively, actually.
And, starting at one of the municipal agencies I was at before, where we started doing 12 leads, and, we're expected to know as a medic what every lead of the EKG means.
Represents, yeah.
Where we're looking at the heart, whereas it never used to be like that. So the education has to follow that. So we can't just say, well, broadly we're paramedics and we don't need to understand everything. No, if you have this piece of equipment that can elevate the standard of care, great. But at the same time, we have to elevate the standard of education as well.
You brought up a very interesting point with, you've got medical control available. And I don't think John's going to fight me one bit on this, but great. Who are you calling? You're calling another ER physician with the same training, and you can kind of chime in, even as a physician, what level of ventilator training you got. But first of all, they're not going to. Whoever's looking at the machine has to be able to translate all of that into something actionable for the physician, and then the physician has to be able to understand and they have to be on their game as far as ventilator management as well. I have come across many a ER physician where I know the ventilator settings before they even spit them out, because they learned one thing and they stick with that one thing, and then they say, I punt to, start here and I punt to RT or whatever.
You mean 100 FiO2, 500 cc's per breath, and 16 breaths a minute isn't what all ventilators are at?
Yes, I know a particular. I know some particular docs. I don't even have to ask. What are your BiPAPs? 10/5 got it. I just didn't even have to ask, right?
Sure.
I knew you were going to start there. But anyway, but if you want to talk a little bit even about your education from a physician standpoint.
Yeah, I mean, I got a good education when it came to ventilators. One of the best things that I had, and shout out to Dr. Andy Yoakum if he ever watches this, and Dr. Heaney. They literally, I was second or third year, they wheeled a ventilator into our recess room as training and said, turn it on.
Yeah.
And we looked at each other like, we poked buttons and it didn't do anything. And then he goes, this is how you turn it on, and reach around the back. It's always on when I go to use it,
of course,
right?
Sure.
And their point is there might become a time when you don't have RT available, and you need to turn the machine on yourself and get it set up, because typically you guys do all that for us.
Yeah.
We come in there, we put the tube, we have a conversation about what the vent settings are, but actually, like, physically touching the machine to change settings is kind of a big thing that was great in training for me. But I didn't get into all the nitty gritty different, all the different modes that there are inside of it, because sometimes it literally got to the point where I'm having conversations with critical care docs and respiratory therapists, and this is my issue I'm having. I don't know what to do. What's your recommendations for? Oh, let's try this setting. I'm like, what setting is that? They're like, we'll talk about it later.
Right.
It's in that menu somewhere.
It is.
Go find it.
And you can talk about E&I ratios and all that stuff, and we'll talk about peak pressures, which we'll talk about. But there's how long schooling for you guys?
We're about a 2-year program at minimum.
So you're a 2-year program to only focus on your specialty.
Right.
I've
exactly.
got 4 years of med school, which teaches me the basic sciences, and then I've got 3 years to learn the whole breadth and depth of emergency medicine. I'm going to refer to the specialist and have this conversation with you guys when it comes to ventilator management, because that's your whole specialty.
Yeah.
And honestly, the conversations I typically have with RTs is I'm worried about hypercapnia, so I want to overventilate the patient, or I want to have a high ventilatory rate or large tidal volume to just accomplish something, right? Or I've got
here's my goals.
Here's my goal.
Yeah.
I got a brain bleed. I want to hyperventilate this patient for that reason. The details of that's your game. This is my goal. How do I get there?
Yeah, and I think that's one thing I'm very thankful for with university hospitals, is that we do have a very good relationship with our physician staff to give us a lot of autonomy, because to your point, we're a big kind of group together, all working to solve the same problem. And I don't understand medicine, and I don't expect, or not all medicine. I don't understand what's going through your head at the moment, and you may not understand what's going through my head at the moment. But the important part is we have a dialogue, and that we let the experts kind of handle their own little areas, and that's oftentimes how it works in our ICUs as well. The patient may come in with intubated, or we intubate them there, and largely the settings have been left up to the RT to decide within protocol, right? So we have certain protocols that tell us we can do X, Y, and Z, and then we let the physician know, hey, this is the tidal volume, the respiratory rate, and PEEP and FiO2, and our physicians will come up to us and say, well, I'm thinking, just as you mentioned, I'd like to do this. All right, this is the problem that we have. How can we address it? And that's largely left to us to figure out.
Yeah.
Well, and you guys do your about hourly rounding anyways on your vent patients, right?
We,
you guys are in
right.
front of these patients way more often than we as physicians
yeah.
are.
Yeah.
And so you're seeing them, and oftentimes maybe I get lucky and I saw the blood gas before you did, and I'll go change something based upon that blood gas, and I see you come around and be like, oh, hey, did you see the gas? Yeah, I did. Oh, I changed this setting.
Yeah.
Oh, okay. Good, then I don't have to.
Get your hands smacked.
Yeah, communication is a big part of that, working as a team. And that's also part of my role too, is working with nursing staff, working with physician staff, whether it's residents or fellows, and providing extra ventilator education, because we all understand that medical school doesn't teach you how to be a top-tier ventilator operator. Even our pulmonology fellows, we're spending a good amount of time teaching them and
that's a good point.
showing them how to run the ventilators.
Sure.
Because ultimately, when they get to that point in their career, it's their responsibility how to run that ventilator. So we spend a lot of time doing that. So I'm thankful for that at our place. Yeah.
Well, I think that's a good segue to just reinforce that you as a lone paramedic are going to be shouldering a lot, and your training, your education has to follow that. And then all of the things that we kind of brushed upon from a physiological standpoint, let's start putting some definition and start kind of talking about ventilator physiology and get into that clinical discussion with what to do with all those numbers and all those buttons. Sure. and what some of them mean. So I guess at a good starting point, unless you think otherwise, is tell us about volume ventilation and tell us about pressure ventilation, and again the volume piece being, I don't want to say intuitive, but at least relatable to the paramedic. Mm-hmm. And then contrast that with the patients that are on pressure modes and
Sure.
and where that can quickly fall apart in, again, the paramedic's mind.
Sure. Yeah. So if you've ever attended one of my ventilator classes, you're going to get some repeat information here. But what I like to do is I like to break it down to some very, very simple points. Okay. The ventilator, in a sense, is an electronic ambu bag. That's really what it comes down to. Okay, we can refine and we can fine-tune every little squeeze of that ambu bag, but really, the ventilator is an electronic ambu bag. And I'm a simple guy. Okay, when I start thinking of how my ventilator is working and my flows and my pressures and all that, I start thinking, okay, if I was squeezing the bag or if I was blowing through a tube, how would I want it to react in this particular instance? All right, so thinking about that the ventilator acts as kind of an electronic ambu bag. We have two different ways to squeeze the ambu bag, okay? We have delivering it with a certain volume. So if I said, hey, Scott, with every breath, I want you to squeeze this bag 500 milliliters. Yep. Then that would be traditional volume control. That's how we ventilate a vast majority of our patients at UH, volume control. We specify a certain amount of volume we're going to squeeze the bag with or deliver with every breath. And then we have pressure control. We have, at that point, telling the patient, or telling the ambu bag, that, hey, I only want you to squeeze up to a certain pressure. And then whatever happens with the volume, it's variable, right? So that's another important point to take home, is that no matter which mode you're in, whether you're squeezing with volume or you're squeezing with pressure, one or the other is going to be the variable.
Yep.
Okay, that you have to, that is the keystone of understanding mechanical ventilation. Yep. You're going to deliver with volume or you're going to deliver with pressure. So the very first thing, if you're coming across a patient that's at a nursing facility is on a ventilator, is you've got to take a look, or if you're setting somebody up on a ventilator, trying to determine, do I want to squeeze with volume or do I want to squeeze
pressure.
with pressure, right?
Yeah.
And understand that the opposite is the variable.
Is what you
right.
is what you could inadvertently mess up if you're not paying attention.
Essentially, yeah.
I love that explanation. I think that's great for our audience. In my mind, I'm guaranteeing one or the other. I'm guaranteeing a pressure with each ventilation, understanding that my volume now is the variable.
Mm-hmm.
So, or conversely, right? I'm guaranteeing a volume, and I might not be necessarily doing that, managing that pressure. So, let's say wrong mode selected, right? They put them on a pressure mode. And they're quickly reaching whatever that target pressure is. Let's say they're obstructed for whatever reason. They're COPD, or just keep it simple, COPD.
Yeah.
So what does that look like as far as performance, and what suffers in that equation?
Yeah. So if we want to think about COPD in general, so what's one of the main problems we have in COPD? We have hyperinflated lungs that are trapping a bunch of air, and that's usually a result of airways that are constricted in a sense, not necessarily asthmatic bronchoconstriction, but narrowing of the airways that is not allowing air to come back out. So we can force as much air as we want in, but it's not coming back out. So the problem then is we get hyperinflated lungs that have pressure built up inside of them, for one, and then two, we're not able to exhale. So we talked a little bit earlier about some of the waveforms we can see. That's one of the nice benefits of these newer ventilators, is we can actually see that occur. But in the case of COPD and you're trying to ventilate them, if you were in a volume control mode, you may start to see your pressure start to increase over time, and that's a result of, hey, I'm squeezing that ambu bag and I keep squeezing it, but the air that I'm squeezing into it is not coming back
trapped,
out.
yeah.
Right. So every time I squeeze, it gets harder and harder to do.
Yeah.
So that would be volume control in that situation. Pressure control, we're telling that ambu bag, hey, squeeze at 20, 25 of pressure every time. And what's going to inversely happen is that the volumes that you receive back are going to
are diminishing.
Drop.
Yeah.
They're going to drop. They're going to come down and down. So that's some of the things we can look at for that situation.
Just a quick point before we get on to the next, kind of physiological point here is, you brought up, the waveform tracing, and much like, we wouldn't go anywhere in today's world without a capnography tracing. Sure. Those pressure and volume tracings, I have to imagine, are as intimate to you, because now you can, I can look at a capnography waveform as a paramedic and say, okay, that's on inspiratory or expiratory side. I'm being very, very, very basic here, right? Yeah. But I know where to focus my, do I need drugs? Do I need bronchodilators, or do I need some other mechanical fix here?
Absolutely.
I can do that with capnography. I imagine you can ascertain that same information, and
Absolutely.
Anybody that is even remotely skilled can see those changes on inspiratory or expiratory sides of the volume or pressure.
Yeah, absolutely. And you can spend an entire semester focusing on just waveform analysis of ventilators. But any seasoned respiratory therapist or seasoned physician in the pulmonary field can look at a waveform from across the room and say, oh, that's an obstructive waveform. Yeah. Or, oh, he's got a whole bunch of pressure building up from one thing or another. Or we have mucus in the lungs. We can look at those waveforms. So great diagnostic tool, for sure.
Yeah, that's then the other thing is all the dials, all the switches, everything it's on. Again, everything's becoming touchscreen anymore. Sure. But I'm using that kind of colloquially. Coming from a time where there were actually knobs and buttons, but nevertheless, some of the common definitions and more commonly used setting. So you guys like to abbreviate absolutely everything.
Yeah, we do.
Like everyone in medicine.
Like everybody in medicine, right? The acronym rules all. But you talk about a little bit about some of the common settings that you would need to set up, kind of from a general, top 6 or top 10,
sure.
Most common things that one would need to spend time focusing on, and then their associated, abbreviation, an acronym.
Sure, yeah. So I'm going to make that even more simpler.
I like
We're going
that.
to break that down into about 5 different settings that
Sure.
we really do need to know. And the nice part about these settings is that no matter which mode you're on, if you're on volume control or you're on pressure control, the vast majority of those settings are all going to be the same. Okay, so if we break this down to volume control and pressure control to start off with, one of the very first things we need to look at is how do we tell the ventilator, how are we squeezing the electronic ambu bag? Okay, we're going to set either a volume or a pressure to achieve that. All right. If we're looking in the volume world, we're looking at VT is the abbreviation, stands for tidal volume. If we're looking in the pressure world, it would usually say P-INSP or PIP, one of the two. When it comes to setting your tidal volume obviously is the amount of air that you're delivering with each breath, or setting your pressure. When we're setting a pressure, actually, we're trying to target a tidal volume, believe it or not. So even though we're in pressure control, we're still kind of, in our brain, we're kind of like in volume control in a sense, but
Right.
using a pressure to deliver it. So we're going to start off at 6 to 8 cc's per kilo of ideal body weight. That's a lot of words to just say 6 cc's really is what we generally go to.
That's why we say 500 mls.
Yeah, and
500
I know
cc's.
that used to be how a lot of things would go, but in the words of one of our interventional pulmonologists at UH, Ben Young, we worked together for quite some time, and he was a resident fellow with us. But when he was in his fellowship and he was explaining to residents how to set the ventilator tidal volume, one of his words were, make the tidal volume look like you thought about it. and it couldn't be more true. And here, as a newer respiratory therapist, I'm standing in the room, and I had thought about it, and I had done the calculation, and I came out with 450 milliliters. And he reached over and turned the dial to 430 or what have you, and I kind of humbly just kind of sat there and said, well, I did think about it, but thank you. But it was a great point to drive across that, like, you do need to think about your tidal volumes.
It's not arbitrary.
Okay? It's not always 512. And that goes along with some very well done research. The ARDSNet protocol was one of the studies. We don't always stick with that, but our protocol in hospitals 6 to 8 cc's per kilo of ideal body weight for just about everybody. Now we'll vary from that. If we have the asthmatic that comes in and is on a ventilator, we may go lower than that, 4 cc's per kilo.
We'll talk about some of those strategies here in a bit. Yeah.
Yeah, but the important part there is that has to be ideal body weight. Okay, if you've looked at chest X-rays of a
obese patient,
60-pound patient versus a 600-pound patient that's the same height, they have the same size lungs.
Frame is the same. Yep.
Yeah.
Yep.
So that's very, very important.
Yeah.
So that's why we do that off of ideal body weight. Now, is it reasonable for the medic in the field to stand there with their Stanley tape measure? And no, but take a pretty good guess. Yeah. That being said, we see a lot of patients roll into the ER where the ER just kind of does the estimate guess, and they get up to the ICU, and then we actually do take a tape measure a lot of times, believe it or not, and we'll measure the patient and say, whoa, we were way off here with this calculation. And is it causing, irreversible lung damage? More than likely no, unless it was way out of the range. But so that's where we stand with tidal volumes. And when we set pressure, or the inspiratory pressure in pressure control mode, we target that same 6 to 8 cc's per kilo of ideal body weight. Moving on to respiratory rate, generally we'll start somewhere between 12 and 18, depending on the CO2 problems that we might have. So generally, we in the pre-hospital setting, we would be tailoring that to their end-tidal CO2.
Yeah.
Right. In the hospital, we're drawing more blood gases than we are doing end-tidal CO2 in their ICUs. But so that'd be your respiratory rate. As far as your FiO2, fraction of inspired oxygen, that's your O2 setting.
Percentage,
so,
yep.
I know in the crisis setting, we always start off at 100%, and that's how we're taught in school. The crisis setting for RTs is actually 60 to 100%. We'll start somewhere in there. But then we also have an appreciation of something called PEEP, which is one of our other settings. So I know there is a lot of push for education around what PEEP is and what it does in the pre-hospital setting. But we use that as another method of oxygenating someone. Yep. So it's a positive end expiratory pressure is what it stands for, keeping some extra pressure inside of the lungs in between breaths to hold the alveoli open. Mm-hmm. If you have some pulmonary edema, you can kind of use that to help get some of that out of the alveoli in a sense. And also you recruit some maybe close down lung tissue by using PEEP. So we may not always start off at 100% FiO2. A good reason or a good scenario that might be in is if you have your CHF patient come in. Those patients, they don't necessarily need a lot of FiO2, but they have a lot of fluid in their lungs.
Yeah.
So we use the mechanical portion,
The pressure to push
PEEP,
it,
to
yeah.
push that,
Yeah.
in a sense, to stem that pulmonary edema or push it out of there. So you'll see us maybe start off at 50% FiO2 and 12 of PEEP. Standard usually to start off with on a normal, everyday, healthy person is about 5 of PEEP, but it's not uncommon for us to be on 10, 12, 14, 16, higher of PEEP, depending on the severity of their pulmonary edema. So some of the other vent settings that we need to, that was 4 of them, but I think one of the other vent settings that we really do need to pay a lot of attention to, and I wish that paramedic programs and medicine programs would pay a lot of attention to this, is inspiratory time.
Yeah.
Okay, or IDE ratio. Depending on the ventilator, it's expressed differently. But inspiratory time is exactly what it sounds like. RTs, we're not rocket scientists, so we come up with good short slogans for everything.
Right.
But inspiratory time could be abbreviated as I-time or T-insp, you know,
yeah.
what have you. But basically, how long are we making this breath go into the patient? Okay, we all have our set predetermined physiologic inspiratory time that we want to do. Mine right now, since I'm talking, is a little bit shorter, probably, half second to 0.8 of a second. You guys at the moment are kind of chill, so yours is a little bit longer.
A little extended, yeah.
If we set that setting inappropriately on a conscious and awake patient, it becomes very uncomfortable. And so we need to pay attention to that. Not only that, but we can also air trap. If we spend more time sending the breath in than letting it out,
yep.
then we run into that problem of building up air inside of the chest and causing problems. So that's your basic 5 settings. The nice part, like I said, is that all of those settings, with the exception of tidal volume and inspiratory pressure, they're all the same in all of those modes.
In all the modes, yeah.
So,
no, that's fantastic, and a couple of things I'd like just to kind of like to chime in there. Specifically with the PEEP, when educating paramedics, I make that natural connection to CPAP, right? Mm-hmm. The pressures are exactly the same pressures. We're doing physiologically the same thing at an alveolar level. Right. It's just a matter of whether we're trapping that in or we're actively kind of pushing that in, depending on the device you're using. There's some variables there, but I think at this juncture, every paramedic is certainly a paramedic EMT level. This is not even a paramedic skill. I'm misspeaking here. Is kind of intimately familiar with that and has seen that work, right? And you've even on some of these lower concentration CPAP systems, we'll say some of these consumable systems where you're plugging them in. By the time it entrains room air into that venturi and it gets to the patient, maybe it's 30-40% tops. They can take that and say, it's that extra pressure I'm dialing in with that knob, on the machine. If you're using a machine-based thing, or on that, which is nothing more than a PEEP valve on top of those most of those consumable things. Just tension on a gasket to help that back pressure in the air. I made that probably a dozen times. The relationship a dozen times in the Airways series that we did. So people are probably tired of hearing that from me, but we already understand that. So that's just kind of the natural progression for me in there. Same thing, if you had somebody on CPAP and you cranked up you cranked your CPAP up and the patient still wasn't oxygenating, then that's the time to start working on that FiO2 or that percentage of oxygen once you've optimized that alveolar distension and that gas exchange. Yeah. So just kind of as an example of where our basic understanding as paramedics kind of get us into trouble with that. I want to work that kind of that I time or that inspiratory time problem that you were just bringing up, that we don't spend enough time thinking about that, because going back to your original your original concept and your original models, we're either targeting a volume with that BVM or we're telling it to stop at a pressure, but I can get the volume in squeezing really hard, really fast, or I can get that volume in squeezing very slowly, and same for the pressure, right? I can get to that pressure threshold. If I'm in a pressure mode, I can get to that very quickly, or I can get to that very slowly. I know of a situation where a department that had an advanced ventilator component to it. We're taking a nursing home patient. They switched them over to their vent, and that entire time the patient was, I don't feel like I'm getting a breath, right? Probably nothing more than it's a comfort level thing because all of their physiological parameters were fine, right? Their SATs, their CAPNO, everything was good, right? Everything that we can monitor in the field. So we were probably matching that stuff pretty well. And the patient's like, I can't, I don't feel like probably was just a slight change for comfort on that time, right? You matched those numbers, but how fast or slow you were delivering it wasn't tuned to that patient. And in response, that crew just continued to add more volume. They added more tidal volume, right? Again, if all you're taught, if you're only taught a handful of concepts, that's what you fall back on, right? If all you got's a hammer, everything's a nail, right? So, but that fits, I think, well with that conversation about we don't spend enough time on it.
Yeah, I agree 100%. And like you're saying, it kind of does come down to fine tuning there. Think back to a lot of us have used the LTV ventilator, right?
Yep.
Did you know you can adjust the rise time or the slope on an LTV ventilator?
You got to
go you got to go in the back menu of that, right? But I can't tell you how many RTs I've had that have not known that you can do that. So
that extended menu.
Right. So you have to pay attention to those little settings as well. And that could have been the case. And that's another point we need to drive home is that when it comes to a patient's synchrony with their LTAC ventilator versus yours, they could be completely different machines, and the way that they deliver the breaths or the way they default with a slope or a rise time or a flow rate, that can be completely different. So their machine may be set on a 0.2 of a second slope, which slope is generally like how fast is the pressure building up that's delivering the breath. But how fast does it ramp up essentially? And then you put them on yours, and your machine has a default of 0.7 of a second.
4.4 is,
So at that point, the patient's going to feel that. And if you don't understand what that setting is, you may be doing them a disservice. It doesn't necessarily mean that something's wrong with their settings. Like you were saying, that patient was on the same settings as they were on their facility ventilator.
Yeah.
But perhaps the slope was different. Perhaps the flow rate was different. The older ventilators, they ran on, a lot of them ran on a fixed flow setting. They only delivered one flow all the time, and if the patient didn't like it, too bad. A lot of these newer ventilators have auto flow built into them, so they look at the machine looks at the previous breath and says, how fast did that patient want the breath to go in? It synchronizes with the patient a little bit more. So that's just settings that we have to pay attention to as a clinician, but that's where the education component comes into it.
Right.
So here are my thoughts on all those settings.
Oh boy.
No.
No, look at this. He actually.
So for volume, I think that I joke about 500, but 500 is often way too high for most people. So in the emergency department, we typically get weights. I don't have a time to whip out my standard and measure what they are, like head to foot. So I go based upon what their weight is, and I think it's a reasonable weight. I just go based upon that weight. Obviously, if they're a 200-kilo person, I'm just going to say, well, an idealized adult, we'll just say was 70, right? Quick, easy math, 70. That's going to put them at 420 cc's of air based upon that idealized body weight if we're doing 6 cc's per kg. So that 500 is way too high, and honestly, I'm surprised. I often end 350 to 400 is really typically where I end when I do that math. So I'll take their weight. That's reasonable. Yeah, we'll just use that weight. I'm using the lower end of it anyways. So if you're going over, I have some wiggle room there. So that's how I do my volumes. For the rate that they're breathing, oftentimes I'm seeing them coming in, unless they're like on a ventilator. I'm not having to modify what their typical vent settings are, but I've chosen to take an airway, or they're obviously going to they're in some respiratory distress and or failure. So I want that respiratory rate higher than what you guys really see on like the ICU, right?
Right.
Because they've stabilized out. So if I'm intubating them, and honestly, and I had this conversation, we've talked about it even with our flight guys, of like the decision when to take an airway and when not to take an airway.
Oh my goodness.
If they're breathing 25 times a second, 30 times, or second.
A second. Oh.
That's how I worked last night. 25 times a minute, or 30 times a minute.
Right.
I don't want to intubate that. I don't want to take away that respiratory drive because I cannot match that on a mechanical ventilator.
Right.
I want to do BiPAP.
Yeah.
Just plain and simple. But if they're breathing at 20 times a minute and I'm going to take their airway, I'm going to match what their respiratory rate was because I'm taking their airway. I want to at least match that. FiO2, I'm a dumb emergency doctor. It goes to 100, but I'll come right back to that. And PEEP always start at 5 for us. Do you want to talk about why it's 5?
So physiological PEEP is something that often gets brought up. So like, and there's studies that go both ways, saying that at baseline we all have a physiologic PEEP of about 5, right? And that comes from the upper airway anatomy that may not allow all of the air to come out of your lungs in between breaths. So that's why we start off at 5. And there's studies to argue either way.
So I also start at 5.
Yeah.
Eye time is complicated for me because I'm often at the higher respiratory rates. I don't have a lot of wiggle room with my eye time. So for me, I talk to you. I'm like, hey, if we're having issues, how can exactly?
Yeah. Generally, our range is 0.8 to 1.5 seconds. That's usually where we start off at. Now, somebody on a higher respiratory rate, we may run a little bit lower than that. But some of the things you have to consider with that is the lower your inspiratory time, the less time you also have for gas exchange. So there's a lot of things that go into that thought process. If we're going to complicate it even more, we think of inspiratory time in relation to the total cycle time. Okay, so if we set somebody on a rate of 30, we have a total cycle time which equals out to be 60 seconds divided by your respiratory rate. So in this case, 60 seconds divided by 30 gives you 2 seconds of total cycle time, meaning how much time do we have to accomplish each breath, in and out.
Yeah.
Right? So if we have a total cycle time of 2 seconds, but then we dedicate 1 second to breathing in, it only gives us 1 second to breathe out.
Yeah.
And then we add in the fact that a normal inspiratory-expiratory ratio, meaning breathing in versus breathing out, is about 1 to 3 on a normal healthy patient. That 1 second of inspiratory time and 1 second of expiratory time, you've now created a 1-to-1 ratio, which could be harmful in the fact that you could air trap.
Yeah.
But at the same time, we have to weigh what's best for the patient. So that's kind of how we think about that. But empirically thinking, you could say the higher the respiratory rate, the shorter the inspiratory time, generally speaking, needs to be. However, if you get too low, like let's say below 0.7 seconds, then you're sending the air in and it's not doing a whole great job at picking up gases and exchanging gases before it comes right back out. So
I'm honestly never saying to you guys set it to this. It's a conversation of you guys honestly to me, hey, can we change eye time? Yes, please change eye time. And I don't ever see us ever going below like 0.8.
Okay.
0.8 to 1.
Yeah, and that's very reasonable. And even in our in our ERs here, we usually don't. There isn't. Or I shouldn't even say in our ERs. I should say throughout our hospital, we don't have a whole lot of conversation with physician staff on, hey, I set my inspiratory time at 0.8 or 1.5 for this particular reason. The only conversations we generally have, or people we have conversations with that about, are our pulmonology team, because a lot of our physicians are like, cool, hey, whatever you think is, what do you think? And it's not to their fault at all. You guys have a lot of other things going on, and we're given a lot of trust and a lot of autonomy to do the right thing, and our staff, I think, really does a great job. But you have to pay attention to it, because if you don't, there could be problems.
It's honestly more of a passing of, hey, I set it to 0.8.
Right, communication.
Great. I appreciate that. Yeah. And then the first thing that I actually do is I change FiO2. I crank it to 100, just that kind of a default. But I have good respiratory therapists that will set it to 40 or 60, because looking at the patient and seeing the picture, they're on 2 liters of nasal cannula. We're just doing it for support, or they feel like they're getting tired out, and it's not an oxygen problem.
Yeah.
They just need the extra help and support of like BiPAP, right? Really for intubation. But FiO2 is one of the first things that I turn down, and I'll just sit there. We put on 100. Oh, it's 100%. I turn it down. We go to 90. Sitting there hanging out. Okay, turn it down. And sometimes I'll overshoot, and I'll bring them down like 60s, 50s, and they're a little bit hypoxic. Turn it back up.
Sure. Yeah.
And then have that conversation like, hey, I got him to 60. Like, oh yeah, I just walked in. There's 100%. Like, I turned him down to 40. I'm like, okay, I just changed it too quickly. It wasn't great for the patient. So that's how I typically do my vent settings, is whatever their weight is, as long as it's reasonable. And again, 350 to 450 is probably the max, but 420 end up around 400 is typical. Respiratory rate is higher. I'm trying to match the patient, FiO2, whatever they need, and talking about whether you're a basic, a paramedic, respiratory therapist. I know you guys know this. Hopefully docs know this too. Hyperoxygen is not a good thing. We actually want to shoot for not it being 100, actually.
Yeah.
And then PEEP gets a little bit different, but those are my thoughts on at least the basic settings of what a ventilator is.
Yeah, and I definitely agree with that. And I think we can also say, throw out a little respiratory secret, that 450 is the new 500. Okay? I mean, if you if you
sure
get
it's not
someone
430.
Yeah, well,
You're gonna get a Dr. Words shirt. I'm gonna get him a 450 is the new 500 shirt.
Yeah, but I mean, if a crew came in to the ER and they passed off a ventilator to me that they initiated in the field or carried over, and they said tidal volume's 500, I'd say, oh, okay. And but if they came in and they said 450, I'd be like, all right, maybe they thought about it a little.
Thought about it a little. I like that a lot.
Yeah, that is a lot of what we do too in the unit. Yeah, of course we don't have the tape measure sitting right there all the time, but in the emergent situation, he looks like a 450.
Yeah.
We come up with a good guesstimate, and then
Same
figure
way
it
we
out later.
guess blade sizes, right?
Right. Yeah.
They look like
a 3, maybe a 4. Yeah.
Exactly.
4 fits everybody. It's just how much you put in. That conversation amongst both of you, two thoughts here. When we're talking about FiO2 titration times, we can just stand there and turn that knob down in the next 37 seconds and get a change on the patient, right? That's how that works, right?
Well,
not exactly.
No. Depends on the patient.
But in general, what I want is, how long it takes for out if we're making
when we're looking at from we're making a change and then looking at a blood gas in about 20 to 30 minutes at the very least. Now, obviously, you can see pulse ox changes within a few seconds to a minute, but generally within 20 minutes. You also have to take into consideration what was the etiology of what was going on.
Of why were they intubated,
like Dr.
right?
Hill said, was this somebody that we just needed to protect their airway? They were on 2 liters a minute, and we put them on 100 because we sedated and paralyzed them, and we wanted to make sure they were hyperoxygenated for that process? Or is this the patient that was, a pulmonary hypertension patient that normally is on 12 liters of O2 at home, and now they came in crisis and we're intubating them? It depends on the etiology.
Whether or not they can exchange gas. I mean, it really kind of comes down to that. At least that's been my mindset is, if I give them normal FiO2, are they going to exchange that gas is kind of where it works in my head. Or is everything banged up in there? Are they the COPD or are they, pulmonary hypertension, great example.